For the eye examination, first comes visual acuity. For this, I asked my patient to stand 20 feet from the Snellen chart. I asked her to cover her right eye and read the smallest line of letters that she can still identify. I asked her to repeat this by covering her left eye. So, 20 by 30 is her right eye. That means 20 is the distance of the point from the chart, while 30 is the distance at which a normal eye can read the lines of letter. Second, visual fields. I asked my patient to look straight into my eyes and I asked her to nod as soon as she sees my finger. I placed my hand 2 feet apart later to her ear and wiggle fingers along imaginary bowl. Confrontation testing of a visual field is a valuable screening technique for detection of lesion in the anterior and posterior visual pathway. For position and alignment, I ask my patient to look straight into my eyes. Upon inspection, there is no protrusion of the eyes. Eyebrows are equally distributed. There is no scaling noted, no edema and redness of the eyelid, or any lesion upon inspection. The eyelashes are directed outwards. Now I ask her to close her eyes and then open. There is adequacy of eyelid closure. Then I checked for the lacrimal apparatus. There are no lumps and swelling. Now I asked her to look up. Then I depressed both the lower lids with the thumb to expose sclera and palpebral conjunctiva. Sclera is white and no redness of swelling noted. Now I asked her to look each side. No lens opacity and concentric shadow noted. Then inspecting the pupil, it is in normal size and shape. No anisoria noted. Now to examine light reaction. To test for the pupillary light reaction, I have to darken the room. Now I ask my patient to look to the wall. Now I perform a direct reaction and consensual reaction. The direct reaction is the pupillary constriction in the same eye. The consensual reaction is the pupillary constriction in the opposite eye. For the extraocular movement, I ask my patient to look at my pen. Both eyes move conjugately and no nystagmus and lid lag noted. Now I ask my patient to follow my pen. I move the pen to 6 cardinal gazes, forming a letter H. For convergence, I ask my patient to look at my pen and follow it as I move in towards the bridge of the nose. For red-orange reflex, I use my pen light as ophthalmoscope. So, you have to hold your ophthalmoscope with your right hand and turn to a zero diopter. Examine the patient's right eye using your right eye. No opacities blocking the red reflex. Place yourself about 15 inches away from the patient and at an angle of 15 degrees lateral to the patient's line of vision. Inspect the optic disc. The sharpness or clarity of the disc outline. The nasal portion of the disc margin may be somewhat blurred. The color of the disc normally yellowish orange to creamy pink. The size of the central physiologic cup, if present, it is usually yellowish white. The comparative symmetry of the eye and finding in the funding. Direct your light beam laterally or ask the patient to look directly into the light. Now for the ear examination, I have to convey my patient that I will be examining her ear and hearing. For this, I have to have a clear vision of her ear. Upon inspection, there are no gross deformities or any lesion noted. For the movement of auricle, and triggers, that is tuck test, the patient has no pain. Now I will have to inspect her ear canal and eardrum using otoscope. I use my pen light as an otoscope. For this, I have to pull my patient's auricle upward and backward. Then I have to hold an otoscope and direct it downward and forward through the ear canal. There is no discharge, redness, swelling, or any foreign bodies noted. The eardrum looks intact. Now, test for auditory acuity. For this, I have to stand 2 feet behind the patient. Now I ask my patient to repeat what I am going to whisper. For example, I whisper CO2. Now again I repeat it from the left side. Normally patients repeat the sequence correctly. Now test for lateralization, that is Weber test. For this I have to place the tuning fork on the top of patient's forehead. Now I have to ask the patient, do you hear any sound on both ears? Normally sounds should be heard equally on both ears. Now to perform Rinne's test, I have to place the vibrating tuning fork on the mastoid. Now I have to ask the patient to tell whenever you don't hear the sound anymore. Then I have to place it in front of the ear canal. Normally, air conduction is greater than bone conduction. In conductive hearing loss, bone conduction is greater than air conduction, while in sensorineural loss, air conduction is greater than bone conduction.